Hello, everyone. Thank you for having me here today. I'm super excited to present to you all a project I've been working on for the last 4 years, which is titled The Future of Human and Artificial Intelligence in Healthcare. A little bit about myself. My name is Setor Zilevu. I attended Virginia Tech for my bachelor's, master's, and PhD. I majored in computer engineering for my bachelor's degree and computer science for my master's and PhD with a focus in human-computer interaction. Currently, I'm the lead UXR at Meta on the content team. I'm also an adjunct professor at NYU, Tandon School of Engineering, where I teach creative coding and applied user experience research to graduate students. My work is focused on understanding embodied learning in the real world for complex machine learning systems. So, what is embodied learning? Hutchins describes embodied learning as understanding the complexity of how humans use their cognitive abilities in a non-simulated environment such as work or sports. And some examples would include playing basketball, flying an airplane, or even cooking. What we see is that we're moving towards a world where machine learning will be integrated into a lot of everyday activities. We see it with self-driving cars and automated chatbots. However, there are still spaces where machine learning stays far away from, and that's when it pertains to understanding human knowledge. We are unique. Every brain is different, and every situation we face is contextual. A lot of human knowledge and behavior is sparse, noisy, and highly variable, whereas machine learning typically depends on good, clean, large data sets. Some examples of this would include having to click through on Google Chrome to distinguish the difference between a cat or a dog, or even asking Siri to find out what song is playing when you hear it. The reason all this is possible is because machine learning models are being trained on good, clean, large data sets. However, when it comes to understanding and predicting behavior, this becomes extremely challenging. It's very easy for humans to agree on the what, but difficult to agree on the why. I love basketball, so I'm going to use a basketball example to illustrate this. If Steph Curry shoots a three-pointer, we can all agree it's a great shot. But when it pertains to understanding why, we're all going to have different reasonings and rationale for why it's a great shot. And that's because every human brain is different, and our context has influenced our decision to explaining why. We know that machine learning depends on good, clean, large data sets, and is very good at understanding and modeling the what, but not the why. Humans are also very good at explaining the what, but not the why, thus making it an extremely difficult problem to create a supervisor for machine learning models. So this is an extremely challenging and difficult problem for both humans and machine learning systems. What I'm going to showcase in this presentation is how I bring human intelligence into complex machine learning spaces where ML typically stays away from because of noisy, sparse, and variable data sets. What we're going to then see is that this is very much a human problem. So a human-centric design solution is critical. I'm going to showcase the human-centric supervisor I created called the Z methodology for understanding the what and the why for complex machine learning systems. So how do we solve for this? We know that machine learning and ACR are at opposite spectrums. What is the solution? We do this by leveraging human intelligence because humans are very good at embodied learning spaces. The real expert is us, the human, not the computer. Machine learning must learn to leverage human intelligence in order to succeed. Now, I know people will argue, why don't you just let the human solve the problem and leave machine learning out of it? And that's because even for humans, there are spaces that are too complex even for humans to see or computationally understand. We have all heard this saying about how machine learning will probably replace the human. However, if we leverage human ability and find a way for the machine to complement that ability, we're empowering the human, not replacing them. So the goal here is to bring human intelligence to synergize with computational intelligence to accomplish two things. First, help machine learning overcome the three barriers by bringing the human back into the loop. And second, by using a participatory design process, I aim to empower, not to replace the human, as to incentivize and reward their participation. Now, let's take a more recent example. COVID-19 has shaken up the world, especially within the space of healthcare. We're walking into a world where health services will need to move from a model that is being delivered to now being transmitted. When we look at the aging population, for them to receive the proper care that they need, and for clinicians to be able to effectively assist them, intensive care needs to adopt this model. And for this model to work, there needs to be computing. If it cannot be computed, it cannot be transmitted. thus making it very difficult to have inclusive health. Now more than ever, it is imperative that humans and computers work together within the healthcare space to create computational models that are transmitted versus delivered to bring inclusive health within these spaces. I'm aiming to apply this ACI methodology within two spaces: home-based rehabilitation and clinical assessment. For home-based rehabilitation, I'm going to showcase first, how do we allow someone to do therapy in the home? Take the necessary information that is needed, transfer it back to the therapist in a summary version so they can make quick decisions about the patient and transmit it back in a way that creates better health outcomes. For clinical assessments, what I'm going to showcase is that embodied learning is an extremely difficult problem. So much of assessment is tacit and not standardized, making it difficult to get all the information that is needed. Also, assessment takes tremendous time for the therapist. So I'm going to showcase how the Z method holds true for home-based rehabilitation and also clinical assessment. The Z method has three iterated and iterative components. First, we must make tacit knowledge explicit. Then we must take that explicit knowledge and make it computable, which is necessary for it to be transmitted. Then we must use computational power to empower the human. And here is why this is super critical. We need to create tools that represent human knowledge, and that's what I did. What you're going to see is that these tools capture and represent and motivates people, which are the patients and therapists, to be better. Let's recap. So far, we know that machine learning wants good, clean, large data sets. However, in embodied learning scenarios, we have noisy, limited data sets, which are highly variable due to human movement. I'm going to showcase how I use the Z methodology to take noisy, limited data sets and include a standardized approach and apply it to machine learning without a compromise to produce great results. Here's a high-level diagram of the Z methodology. This method shows the relation of processes and interfaces to power human intelligence through computing in a nonlinear fashion. The interface facilitates both the human and computer on two fronts. Qualitatively, it allows expert knowledge to transform from tacit to explicit using a participatory design approach and moves clinicians from an unstandardized approach to standardized assessment and capture process. Quantitatively, it provides explicit computational data for machine learning systems to begin to model and understand how human behavior is to not replace the human, but feed back into the computational human intelligence. And so what I'm going to showcase is how through each iteration, we're going to see how the human improves, the interfaces get more refined, and the machine learning systems get more advanced, which ultimately means we've reached a point where we're empowering the human throughout this process. Now, when I say humans, I'm speaking primarily about stroke patients and occupational physical therapists. In these next two slides, I'm going to showcase the patient experience and the therapist experience. Here, we know that the patient's primary goal is to get better and return to a sense of normal human movement after suffering from a stroke. Currently, the process of rehabilitation for patients is synchronous. The time, transportation, and cost make it difficult and frustrating for many patients to receive the care that they need. However, let's imagine an asynchronous approach where patients can perform the rehabilitation in their home. That will reduce the time, the cost, and transportation tremendously and allow patients to receive the same high-yielding outcomes just as they would in the clinic. For therapists, the primary goal is to provide high-yielding outcomes to patients. However, within the clinic, it's very difficult for therapists to have personalized time with patients. 15 million people. That's how many people suffer from a stroke worldwide each year. If we narrow the scope to just the United States, that's equal to someone having a stroke every 45 seconds. The positive side to this, however, is that more and more people are surviving from a stroke. But because there are far more stroke survivors than there are therapists, we need to adopt an asynchronous approach. And if we adopt an asynchronous approach, therapists can now begin to provide better health outcomes for more stroke survivors. So the two research questions that I aim to answer to create this methodology are first, how do we develop an ACI design method that integrates human intelligence with computational intelligence? And second, how can we use this methodology to then empower the human versus replace them to incentivize and reward them in this context? And so I'm going to showcase how the Z methodology, how I took this methodology and applied it within the space for healthcare. We're going to walk through and I'm going to showcase how the rating interface, the capture interface, and empowerment all come together to synergize human intelligence and machine learning intelligence to empower humans. So I'm going to showcase how I apply the Z methodology to the Setor system, which is the semi-automated rehabilitation at-home system. The Setor system was developed by a multidisciplinary team at the Interactive Neurorehabilitation Lab at Virginia Tech, which is now at USC. The system was designed and developed to provide a semi-automated cyberhuman approach to capturing in-home rehabilitation. The Setor system aims to provide a low-cost, semi-automated way for motivating patients to complete therapy at home while still giving real-time feedback similar to what they would receive in the hospital. And so here's the setup of how the Setor system works. It includes 3D printed objects which replicate the activity objects in which patients use in the hospital, a custom design mat, a web application tablet which acts as the voice of the therapist, markings on the mat indicate the object placement and activity space, and 2 low-cost cameras to capture the data of the patients performing different activities. The first step within the Z method is to make tacit human knowledge explicit. And in this case, it means understanding the implicit internal mental model of therapists and best ways to bring that knowledge out in a manner that's explicit. And in this phase, I'm going to showcase how I worked out the structure, the mental model and mind of the therapist in a way which can be understood. So I begin this process by first developing and creating the rating interface, which facilitates how I transform expert tacit knowledge into explicit knowledge. I aim to answer the first barrier faced by machine learning systems, and that is, how do we bring out human knowledge in a way that is both explicit and standardized? And what I'm going to showcase is how I use the rating interface to facilitate this process to accomplish 3 key things. First, it brings forth expert human knowledge. Second, it's going to allow therapists to better understand their own practice. And third, it will structure the therapist thinking with us in a way which is standardized. And all these things are going to occur simultaneously through an iterative participatory design process. And here's a quick visual of how the video application tool looks. I'm going to walk through in the next slide the components of the video application tool and how it came to life. In order for us to reveal the tacit expert knowledge, our team worked with expert therapists to develop a rating rubric and movement taxonomy. Essentially, what we did was break down the key movements that a stroke survivor would typically do in different segments. We're asking the human, not the machine, to filter out what is important versus unimportant, which is a huge change in how people think about machine learning. In most cases, people ask the machine to do all the filtering. With my participatory co-design process, I'm asking the human to do the filtering and tell us what it means. We created a rubric. Now we had to enact this rubric to see if this process works for the therapist. And that's typically how the brain works. We have no idea the different layers in which how a therapist thinks, how they interact, but we do know what those layers are. And so the only way to understand how those layers work was to go through this reflective process of assessing them through the rubric and rating the videos. I developed the video application tool to assist therapists in revealing their expert knowledge. This tool helps both the therapist and our machine learning agent structure expert knowledge in a way that is standardized and quantifiable. This works through an iterative process that allows computational human intelligence to improve gradually into empowerment without losing granularity across the 3 layers. This tool facilitates us and helps us reveal tacit to explicit to get into empowerment. And so this was done through using Fitzpatrick's framework, which provided helpful ways for us to think through and see the different levels of reflection. And so this is a participatory approach, which is co-designed by the therapist and to showcase the data back to them, who become the expert tool users, which means that the outcomes that we're getting are strictly defined by the therapist. So now, how do we make explicit human knowledge computable? In phase 2, I focus on understanding how do we make explicit human knowledge computable. Through the use of the video application tool, I developed a way to first understand and take the mental model of the therapist and bring that to life. But that's not enough. We have to find a way to take that knowledge and now make it computable. We have to switch from tacit to explicit to now computable. And so what I'm going to showcase is now how we go from an unstandardized process to standardized process to the video capture, which I call CI, which feeds into our computational machine learning system. Like I said earlier, the capture interface acts as the voice of the therapist. What you're seeing here on this screen is a tablet interface that we designed that walks patients through the step-by-step instructions for the different exercises in which they had to compute. And so it walks the patient through in an in-home setting, the different instruction sets they would have to do before performing an activity. It reminds the patients to make sure that they're setting up correctly and lets the patient know which exercise they're going to complete. It allows the patients to watch a video of the exercise, and then the patient then taps the screen to begin their exercise. When they tap the screen, there's two cameras that are turned on, which are to record the patient's activity. Afterwards, we give the patient high-level feedback to let them know how they did. We tested this out with patients at Emory University, and what we realized was that giving them high-level feedback was not enough. Patients wanted more granular feedback, and so we had to figure out a way to empower both the patients and the therapist. And so what you're going to see here is how we kind of move from that approach to create an explicit computational model using OpenPose. OpenPose is a deep learning model that creates 2D and 3D skeletons of the joints. And so what we did by capturing high quality standardized video quality data of patients, we see that OpenPose can generate 25 key points of the upper body. And when placed on top of the actual video data, we see that overlaps. And so we use the raw video frames for analysis, but then also we understand through the video application tool, we have the therapist's mental model in mind for understanding how does the therapist structure and rate these different videos. When we begin to start to combine those two together, we now start to move towards the phase where we're moving towards computational intelligence to empower the human. Now I'm going to showcase how we bring and synergize both human and AI intelligence together to now empower the human. In this stage, we're going to combine both the rating interface and capture interface together to empower the human. The goal here is to have the therapist and the patient utilize both interfaces to showcase how we can promote new levels of reflection and make them better throughout the process. What we see here when we look at this is the relationship between explicit human computational knowledge and machine learning computations. At the top, we see the composite features average over the kinematic features for difference, which is a machine learning model. At the bottom, we see the agreement over the number of total observed, which is the therapist's probabilistic space of using the rating interface. What you're looking here when we see this is that there's over 19 million different combinations that a therapist must go through internally to figure out and assess the movement, human movement of stroke survivors. What we see is that it's not deterministic, but probabilistic, as we see in zone 4. Now we've reached a point in which we understand from a human-centric standpoint what the most probable cases in which the therapist is going to use an assessment for patients. And now, because we have that, we can now combine that with the composite features after the kinematics features to now create a relationship for the machine learning model and the human model to then start to produce semi-automated feedback for stroke survivors. And see, the reason why this is possible is because a machine learning model cannot understand the different combinations like a therapist can. For us to get to this point, we needed a therapist's expertise. What my research showcases is why this is a probabilistic area and not deterministic, is because the machine learning models typically find it extremely difficult to understand the middle ground between these different tasks. And so to solve for this, we needed the machine learning model to be based off human-centric data. This is critical because it gives us the combination that the therapist used to generate the different scores. By using a human-centric approach, we solve for this by creating a relationship between those combinations that are in the therapist's head while rating the different tasks to the raw kinematics, understand how to create a model that understands impaired human movement data. Now, people will say, why don't you just teach the model? But there's an easier way. There are 40 composite features. That means there are 9 million possible combinations that the model needs to fully learn to understand how the hierarchy works. And therefore, by using this human-centric approach, it's critical for informed machine learning for human behavior because it then shrinks their interpretation space for them to understand this is the most probabilistic spaces in which the human mind works to understand these different combinations. What we're seeing is that the therapists have these features in their head, what they did. What we're seeing is that it's revealed to us through these possible combinations. The kinematic features gives us the quantitative visualization of the tacit information, what you're observing versus what you cannot observe. And so from the therapist, they wanted to be able to use this now to be able to see and do more than they could have before. One feature that came about this was that the therapist wanted to see at the most granular level what the human eye cannot see. And that's how we synergize the rating interface and capture interface together to now empower the therapist to see more than they could have before. And here's an example of what I mean. The therapist can see a lot, but they cannot observe everything. When we look at this video, as the patient is initiated and grabbing through, you see it's now zoomed in to allow the therapist to see more details and fine-tune to see exactly what fingers are being used to observe. This is going to transition into the different movement segment. It's going to transition to move to the different views that the therapist would see. And so the camera is now going to adapt and change the angle to now to model the human mind of the therapist to see the patient's producing the moving the object to the top and is going to move it back down to the bottom. What we see is that now, through the use of this interface, is adapting and changing to the view of the therapist and now allow the therapist to see much more than what the human naked eye could see. The therapist can observe a lot, but it cannot see everything. And so the goal of this methodology is to empower the humans to be able to reach new levels of reflection and to be better. And as we move towards this, we're moving towards empowerment summaries that allow the therapist to be able to see more granular levels of different human movement performance features. And so I want to close by saying, if you want to bring machine learning into complex spaces that have complex meaning, it's very hard to supervise that space. You can get people to agree on the what, but not the why. And so what I created was a supervisor for training machine learning model for both the what and the why. And the only way to do that is through a human-centric supervisor. Throughout the middle here, we see the computational engine, but it starts and it ends with the patient and with the human. The patient is used throughout the capture interface to allow this computational engine to work. And it ends with the therapist who uses the rating interface then to rate and assess. This is a human in a loop problem, which has the human at both sides of the spectrum to feed into the computational model that we've developed. And so now, how does the Z methodology impact artificial intelligence? First, it creates a standardized process to allow humans to reveal both the what and why when assessing human movement. Two, it creates a probabilistic relationship between movement functionality and movement quality for both humans and machine learning systems. And three, it reveals and transforms implicit knowledge into explicit computable model that can be understood by both clinicians and machine learning agents. The future of humans and artificial intelligence in healthcare. As humans continue to develop and refine their workflows and body spaces, the Z method allows interconnected interface to continuously adapt to better support both humans and machine learning systems. And also computational models that are continuously created, processed, and assessed by human level data that understands the mind and mental model of humans in complex spaces. And with that, I end by saying thank you.